next speaker, Dr. VIKAS MITTAL, who's again a cornea surgeon, cornea and cataract surgeon, and of course refractive too. And he is from LG Institute, Ambala. And he is going to be telling us about simple limbal epithelial transplantation, pearls for optimal outcomes.
Thanks so much. I'll share my screen. So hope it is visible.
Yes, yes.
Okay. Thanks so much, AIC, ARC, and Dr. Brahmurthy for giving me this opportunity. The topic given to me is that how do we have an optimal outcomes after SLET? So first of all, we'll have to understand that what are these optimal outcomes. So if a cornea or eye, something like this, becomes something like this will be a desired outcome. If we can have cosmetic, structural, as well as functional improvement after SLET in an LSCD patient, it will be a desirable outcome. Firecracker burn, severe LSCD, after SLET, you can see shining cornea, clear center, patient can see excellent outcome. Even if the cornea is not transparent, even if it is opaque, if we can have a surface, stable surface, we can do a penetrating keratoplasty or any lamellar keratoplasty later. Comparatively, milder stem cell deficiency will have a better outcomes. But for these results, how long these results are going to stay? So what are the long-term effects? This boy underwent SLET around 12 years, rather exactly 12 years from now. He had a tuna injury, and all these 12 years, the surface has been stable and child is using contact lens pretty decently. You can see even for the long term as well. So what are optimal outcomes? The epithelium on the cornea should be corneal phenotype, and there should be no ocular surface issues like persistent epithelial defects, inflammation, and these results which we achieve should be long lasting. This is what the optimal outcomes is. Little backgrounds, what happens in these eyes is this beautiful structure, which is a barrier, the limbus, this is missing. There can be many reasons for that. Most commonly in our setup, we see chemical burns. What do? If the limbus is damaged, we have to restore it. And at present, SLET is the technique of choice for stem cell transplant, and it is followed all over the globe, thanks to Dr. Sangwan, who invented this technique, and we don't have to depend on stem cell lab these days. What we do is take a limbus tissue and we do a in vivo cultivation in the patient other eye which has a limbal stem cell deficiency. The individual limbal pieces gives rise to epithelium, and over a period of 2 to 3 weeks, it covers the whole of the cornea that we had shown in our study as well. This corneal epithelium has been proven to be of corneal phenotype only. So now the question comes that what all we do clinically so that we have a best possible outcomes. I have divided into 3 headings. So let's see what we need to do before, during, and after the surgery. So before surgery, I remember a call in the middle of my OPD. I got a call from my Ophthal friend. He said, "Vikas, you had shown me SLET videos the other day in one of the talk. I've got a patient and I want to do a SLET. Please send me videos once again." I said, "Okay, so can you share the preoperative photographs of your patient that you want to do a SLET in?" He sent that. And these were the photographs. You can see dry, keratinized surface, hostile atmosphere. How will those limbal stem cells will survive here? So dry, keratinized, not at all. Even if the eyes are wet, if there's a continuous inflammation in the form of OCP or continuous mechanical insult in the form of lid margin keratin, these are the eyes where you'll have a suboptimal outcomes after SLET. The best eyes are unilateral LSCD and which are wet. You can also use with the after excision of OSSN, if it is VAS, you can do SLET in the same setting and have a good outcome. So overall, wet eyes, non-inflamed surface, these are the best possible atmosphere for the cells to grow. Next is, when do we operate? In our study on pediatric SLET, what we found was from the duration between the chemical injury and SLET, the average time was around 6 months. But all these were grade 6 burns. And the issue is, in these grade 6 burns, in general, sometimes take 3 to 4 months for the epithelium, for the surface to get epithelialized, even if it's a conjunctival epithelium. So we need to wait. The timing is, if preferably it has epithelialized, the surface is epithelialized, even if with the conjunctival epithelium and the surface is minimally inflamed. So now comes the surgery. So there are few steps. We'll straight away go on the surgical video. So first step is taking limbal biopsy. These are the palisades that we want to harvest. Most important step, start with a superficial dissection, 4 to 5 mm. This conjunctiva will give you a handle, and you must not touch the tenon. I'm cutting all the attachments of this superficial structure, the conjunctiva. Once I've reached the limbus, the bleeding shows that this is the posterior limbus. Now I'm using blunt size of 15 number blade. The end pointed, you should go in 1 to 2 millimeter into the clear cornea. So this is the now dissected limbal biopsy dissection. So now first I'll cut the conjunctival tissue, which was actually helping me as a handle, and then limbal tissue. The scissor should be flat, and you should cut slowly and you should ensure that these palisades are very well preserved. So once you have taken the limbal biopsy, now the patient's LSCDI is draped. First step is 360-degree peritomy. Need to cut off all the fibrous tissue. This fibrous tissue is generally the under the conjunctiva. Ensure that your globe is free, is freely movable, and there are no surface, no fibrous tissue. And then you come on the center, and you can find this plane in the for cutting this fibrovascular pannus. And once the whole thing is removed, the whole pannus is removed, you place a wet amniotic membrane over this surface. This is a very important thing, that because this amniotic membrane is going to provide a basement membrane over which these cells will grow. So this is secured very well with the fibrin glue. So what I'm doing is I'm securing first the upper half of the amniotic membrane, then I'll secure the lower half, so that the fibrin glue is very well placed. You need to be very comfortable with the fibrin glue. So excess of amniotic membrane is cut or can be tucked underside. Over this, the limbal biopsy pieces are, this strip is placed. I am cutting it into multiple pieces, try to keep the epithelial side up, and place it into the two rings. One will be just inside the limbus, and then the other ring will be mid-periphery. I'll avoid the center. So center we should avoid. So I'm using first the thick part of the fibrin glue, and then thin over it, and then all you have to do is just nudge these explants, just touch it, so that the ensure that the fibrin glue goes inside. Wait for good 8 to 10 minutes, and then you can place a bandage contact lens, and you can do a suture tarsorrhaphy as well. Sometimes the inside the cornea, after you have done the pannus dissection, you can see the cornea is absolutely clear, and these are the patient who have a very good visual prognosis as well. You can see, and if you have done an AMG during the acute phase, removing this pannus is extremely easy. So we learned a few things for limbal biopsy. This was my first SLET. So you can see the donor site had a limbal stem cell deficiency, and the reason for that is we went a bit deeper. So I learned that you should not have a deeper dissection. You should stay superficial, and if you are staying superficial, later on you can't even make out what was the donor site, and it heals pretty well. Another thing that we have learned on the way is in the early cases, we could see some focal recurrences of LSCD, and these were managed very easily with CAG or conjunctival autograft, which told us, or which we learned, was it is not only the damage of the limbus, it is the damage of the conjunctiva also that you have to take care of. And what you can do is you can do the CAG while you are doing your primary SLET itself. So you can see here 360-degree peritomy and cutting off all the fibrous tissue, and I'm ensuring that my globe can move all through, so that there is no fibrosis left. And then center area you can take while dissecting. So I'm starting from here, so I'm taking a CAG as well as limbal biopsy. So once I come here, it will be only 3 millimeters. So this will be a large area, so you can place a conjunctive AMG to cover it. Now you can just cut these CAG into 3 pieces. You have to cover at least 3 to 4 millimeter just adjacent to the limbus. This part will be sutured with tenno nylon, and the distal end can be secured with fibrin glue. So I have not placed the AMG yet. So I'm first securing the CAG tissue, and then I'll place a amniotic membrane over it, and then the same steps, amniotic membrane, and then later on these limbal biopsy pieces. So can we do SLET
1 minute
without
remaining, sir.
AMG as well? Yes, if you have, this is a 180-degree limbal stem cell deficiency, but you can see that this tissue is after pannus is resected, it is pretty smooth. So if it is pretty smooth, you can place these explants directly without amniotic membrane. And this cornea epithelium was pretty good, so I didn't want to touch it. You can see this, and the same patient you can see had a very good outcome. The tarsorrhaphy, we do a lot of tarsorrhaphy if you have extensive LSED. So after SLET, do a tarsorrhaphy as well. Post-op, steroids for 3 to 6 months, depending upon the surface inflammation. Generally, you need it for first 3 to 4 months. Lubricants, you keep on going. You check how's your BCL, AMG. I remember this girl. This was, I think, 10 years old photograph. So I could see this, brownish looking thing which was under the AMG, and I got scared that I've got an infection. So I made a cut, but actually it was just blood which had collected and drained off. The patient did well, and this scar tends to faint over time. So what Harsh had shown, those patients, you just wait. These scars, they tend to faint over time, and you can easily use RGP or scleral lenses. Rarely you can use, this is a very early patient, so we had done FALK. Patient did very well. You can do penetrating keratoplasty. You need to be careful because chance of rejection will be high. But we have a handful of patients who have undergone PK after SLET and doing pretty well. So overall, if you just take care of pre-op, choose your patient well, choose your timing well, do a meticulous dissection, place your, ensure that wherever the conjunctiva is lost, place a CAG also. If you can do that, take care of this, you'll surely have a smiling SLET patient and smiling surgeon. I would like to thank my mentor, Dr. Sangwan, from whom I have learned all this ocular surface stuff. Thank you so much.
That was a wonderful talk, Dr. Vikas. I think it answered all the doubts. Would Namrata want to ask anything, or shall we go on to a last speaker?
It was covered absolutely complete. Dr. Radhika, would you want to add something? I think it was a very complete talk.
Nice talk. It covered all the aspects and with very practical suggestions and good examples.
If you've had a failure of auto after an auto SLET, when would you repeat it?
So that's what. So generally, with failure, you generally tend to get a focal recurrences. So just see if the focal recurrence is small. All you can do is just place a CAG. That's it. And in case you have, over the limbus also, you should wait for good. We generally wait for 1 year, and then see if the center is clear with contact lens, vision is fine, no need to touch at all. But if it is coming to the limbus, to the center of the pupil, then yes, you might have to repeat. But if you repeat, ensure that you do a CAG as well, along with maybe you can do a mini SLET. Important point while doing a repeat SLET. So donor area, you should leave at least 2 clock hours and then take the next limbal biopsy piece. So it should not be adjacent. That's what you have to take care of.
That was wonderful. Yes, wonderful.
Because just coming to my question, have you ever taken
yes,
stem cells from the same cornea?
Yes.
Because there is no other eye is not there. And,
yes. So in your patient, Harsh, I'll not do anything. So you said that patient can see something. So we'll try to give contact lenses, maybe scleral. So we have seen many a times, I'm sure Dr. Namta and Dr. Radhika would agree that, once for these corneas, when you place a scleral contact lens, if the patient has 1 meter, he may see, 660 or 636. The issue with taking very small area, you might land up into, even more limbal stem cell deficiency. We had seen one patient, but the other eye was also bad. But there was one area, from where we could take it. So we just took very small piece and did it. In case you feel that you'll have to do it, then I think this is an indication for CLET. And SLET should not be done. So you take it.
You can even do a cadaveric SLET if at all.
Allo SLET from
Allo SLET is a different ball game altogether. Allo SLET means you have to be ready with immunosuppression and all. So yes, that's right. You can definitely do it. You'll have to use immunosuppression. With immunosuppression, you can do it for sure.
What is the preferred drug for immunosuppression, Dr. Vikas, if you're doing a halo SLET?
So allo SLET, that again depends what drug you are comfortable with. You can use mycophenolate plus azoran. So what we generally do is, in case we are doing allo SLET, we give IVMP maybe every month for 5-6 months, and we give a combination of azoran or you can use this endoxan or mycophenolate. So what I feel is we should be what we are comfortable with, which drug we have used, we should use only that drug. So I generally like azuran, and with systemic IVMP, intermittent shots, I think that works pretty well for me. But again, we have to be careful for when we are doing it using in a young patient. So ensure that patient has completed his family, all those things. I think those things are very important.
Thank you.